So today is the last day. We just will be more of a whatever we have done in last 3 days. So we will recapitulate whatever we have done in last 3 days. So more of a revision for you. Only thing is that you have to conduct exams. Theory exams will be of MCQs, which will be of 40 marks, and that will be for 45 minutes, and followed by practical exams. I just want to know how many of you wants to leave before 2 o'clock? Before 2. No, see, it's the matter is when we take a simulation exams, each group would be called. Each group will be having 25 minutes. Okay. So we'll be starting at around 11 o'clock or so. But only thing is that those who wants to leave before 2 will take them in the first group so that they can grow easily after appearing to the exams. The second option was that we was thinking that first take a practical exams and then theory exams. But in that case, those who want to leave before 2, they will miss theory exams. So there are only few people planning to go before 2. Then we can definitely take a theory exam first, and then we can take for a practical exams. How many of you want to go before 2? 3. Before 3. Okay. So you can all be in first group for those who want to go before 2 or before 3. But I think by 4 or 4:30 we should be able to finish everything. If there are few lectures that is remaining, that will keep it after those who leave. So whatever important lectures we call before that. So now come to troubleshooting. See, yesterday we have discussed about the mechanical complications and how to deal with the mechanical complications and how to do mechanical issues. Now we'll discuss in general about how to manage the patient and what are the probable problems you can get when you do an ECMO case. So ECMO is a blender of man and machine. Complications can be either machine related or patient related. And remember, for all the troubleshoot, whichever you get, the victim is always first without technical issues. The reason is technical issues are easy to diagnose, number 1, and number 2, they are life-threatening, and they can be rectified immediately. So if you diagnose it, you'll be able to diagnose it easily. If you look at it, it can be rectified, 100% correctable, and can be life-threatening. As simple as, suppose by mistake the oxygen gets disconnected from the oxygenator. It's a very simple issue, but the patient who is dependent upon that goes into hypoxia, and you keep on thinking of some clinical conditions without thinking about the technical issues. The patient will die within the next 5 minutes. So that is the reason always, because technical issues will never give you time. So that's the reason always whenever something goes wrong with the patient on ECMO, always think first thing about the technical issues. Once you get all the technical issues are okay, then you think about something which is related to the patient. Because patient related may not be that life threatening, and that will give you some time to diagnose and then treat. So what are the technical issues? Can be something wrong with the calibration of the machines, pre-pump, pre-oxygenator, post-oxygenator pressures you have to monitor. That will give you most of the information. Your flow rate, blood flow rate, swift gas and RPM relations that you have to see. And you have to see check the connectors. If you look at all these things, you will be able to get most of the answers about the technical issues. So what are the troubleshoots that you can get during the course of ECMO? First thing is poor flow. You may not be able to get adequate flow. Second is In spite of being on ECMO, patient is hypoxic, saturation is low, less than 85, less than 80. In spite of being on ECMO, patient is hypercapnic, CO2 is high, hypocapnia, tissue perfusion is still poor, you are not able to adequately support the patient, oliguria or patient develops hemolysis. These are the common issues that can come across whenever you see the patient on ECMO. So first we discuss about poor flow. So once you put the patient on ECMO, patient on 5 liters of flow, and suddenly you don't get enough flow. The staff comes and tells you the flow has decreased to 2 liters or 3 liters. So that is, you are not able to get proper flow. So what you need to do is first look at the negative pre-pump pressures, how much it is, whether it is -5, -10, -20 or more than that. If it is more than -40, then that means there is something you need to infuse the fluids. Look at technical issues. Muscle is properly calibrated or no. Pressure in the blood line. See, many people, previously, if you connect your pressure lines to the monitor, okay, if the blood is there in the pressure lines, you will not get able to get the correct readings. So that's the reason you have to rule out that first thing. If there are no technical issues, then you have to think about issues with the patient related. If it is occurred suddenly, flow was okay and suddenly the flow goes down. Okay. One of the cause can be there can be a kink in the circuit or cannula malposition. So especially this can occur, especially when the patient has been given some position or patient has passed motion and stop start planning to clean the patient. During this kind of episode, this thing happens. So you have to always find out what has triggered this and how it does it occur. So again, this is easy to clear it up. Not a constant flow. Flow is fluctuating. So it's not that flow is constantly low. It is fluctuating. It is fluctuating with 3 to 5 liters. And this can occur when patient is agitated or patient is breathing. If there is a ventilator patient dysynchrony or patient is agitated, that is the time you get fluctuating flows. So the flow is constantly low, that is a different story. If the first flow is fluctuating, it means patient is either agitated or it is fluctuating with the inspiration. So in that case, you have to sedate the patient and if required, use muscle relaxant also. If the flow has gone gradually, then you have to think about something which is seriously related to patient. In that case, you have to think about first possibility is hypovolemia. So you can give some fluids and see how the patient behaves. Okay. Second possibility that can remain is the cardiac tamponade, either in terms of pneumothorax or pericardial effusion that causes decrease in the flow. And third possibility is your cannula size is small. You have to add one more cannula. So these are the reasons where you can get poor flow. So always first think about always check about the technical issues. If there is no technical issues, see if whether the flow is fluctuating or not fluctuating. If it is fluctuating, most of the time it is because of agitated patient. Just give sedation, you will get a good flow. Okay. And third is give fluid. If the no response to fluid, get an X-ray done to see what is happening. If the cardiac seal out is increased or there is a pneumothorax, you have to treat that. In spite of all that, you are still not getting good flow. Cannula malposition can also be there, but once you do an X-ray, you will get to know even the cannula position also. And still you don't get proper flow, then don't wait for a long time. Think about putting one more line for a drainage and make it a VVV. Okay. So how do you diagnose poor venous drainage? You get suction effect on the catheter. That is what I was showing you, the scattering effect. High negative pre-pump pressures and decrease of pump flow with the same RPM. So you can diagnose with scattering, reduce flow and increase suction pressures. What you do once the patient starts scattering, You have to reduce the RPM, don't increase the RPM. Otherwise, chattering will further worsen and there will be a suction effect on the vessels. So once you see a chattering effect on the tube, what you need to do is decrease the RPM till the time tube gets settled. At the same time, start fluid. And once you come down to the RPM, then gradually go slowly up on the RPM. And meanwhile, you have to see the patient is restless, agitated, seated, the patient give fluids. Okay. That is the way you have to manage the settling. So causes of poor venous drainage: cannula too small, cannula malposition, kink in the lines, hypovolemia, patient restless, tamponade effect, either because of pneumothorax or pericardial effusion. This is the you can diagnose. This is you have to treat. The another issue you come to across is inconsistent ACT. Sometimes staff comes and tells you ACT is 180, 200, 160, and then suddenly they say ACT has come down to 140, or suddenly they say ACT has gone up to 200, 220. So inconsistent ACT. The patient might be bleeding or they might be not be bleeding and ACT is inconsistent. What are the causes of that? So what are the causes that the ACT can be fluctuating or inconsistent is? Number one, platelet, any blood product transfusions, platelet transfusion or FFP transfusion, that can lead to inconsistent ACT. Because what happens when you give to platelet transfusion or when you give FFP, the ACT level will go down. Okay. So always, if the patient is not bleeding, you are giving FFP or platelet, you might have to give a small dose of heparin. If the ACT is on a lower side. If ACT is more than 200, you need not have to give it. But if ACT is lower, then you have to give at least 1,000 units of heparin in an adult or before you give a platelet or FFP transfusion. If it is more than 200, you don't require to do it. Second thing, after you give a transfusion, you have to check the ACT again. Okay, what is the ACT level, and then you have to adjust heparin accordingly. I told you, think of technical issue, machine malfunctioning. Then, when they increase urine output or decrease urine output, even heparin clearance is by the renal function. So the renal function deteriorates or renal function improves, your ACT can fluctuate. Okay. You dialyze the patient, your ACT will fluctuate because the heparin clearance is more. So whenever heparin clearance is altered because of renal functions, you might get change in the ACT. Okay. Patient goes in DIC, again the ACT will fluctuate because of clotting factor deficiency. And when there is antithrombin 3 deficiency, you will get something known as heparin resistance, and that will lead to decreased ACT. So, if on day 5, day 6, day 7, if your heparin requirement goes up, okay, that means there is antithrombin 3 deficiency, and in that case, either you give FFP and supplement, but again the concentration of antithrombin 3 in FFP is too less. So how much FFP you give, that becomes a question mark, or you keep on increasing the heparin dosage. Next is carbon dioxide, hypercapnia. So what are the causes of hypercapnia on ECMO? Technical, your sweep gas is less than what is to be ideally. So first thing is there can be a disconnection or leakage or blockage of the gas line. That is one most important thing. And this is what actually we have seen. I've been to one place where we put the patient on ECMO, and there was, once I put the patient on ECMO, there's no blenders was, our blender was not getting fit into their oxygen socket. So it was there in the night. So they said they're making it, the engineer will come in the morning and we can connect it to the blenders in the morning only. So fine, you can always manage with your central oxygen, because anyway you are starting with 100% FIO. So even if you connect your oxygenator to direct to your flow meter, that should be fine. And we did that, and we started ECMO, and we started the flow. We started with 1.5:1, and once I got an APG done, the CO2 was around 50. I said, okay, I will increase the sweep gas, and we went up to 1.5 and to 1 also. And then also the sweep, in each APG, the CO2 level was going up and up. So I said there must be something wrong in the flow meters, and we changed the flow meters, and suddenly after changing the flow meters, the sweep gas, the CO2 has come down. The CO2 was gone up to 100, which immediately after changing the sweep gas flow meter, it came down to 40. So that is one of the reasons that you have to always check. There can be some leak, blockage of the gas line or disconnection. So always whenever you are in doubt about some technical issues, better to change that particular part or component. That's most important. Sweep gas is too low, patient is restless. So whenever the metabolic activity increases, definitely the CO2 production will be more, and that can lead to hypercapnia. More cardiac output, oxygenator failure in terms of membrane edema. That is what I told you yesterday. If your staff forgets to flush the oxygenator for say 12 hours or 24 hours, you will start getting returning CO2. So what you need to do is you have to increase the, you have to see that your staff does the proper flushing of the oxygenator. Oxygenator failure, that will be clogging or emboli of the oxygenator. Again, that will decrease oxygen function and leads to hypercapnia. Or again, the high cardiac output state, for whatever reason, maybe the demand is more than the flow, then you get a hypercapnia. Hypocapnia, usually your sweep gas flow rate is more than what is expected. So that can be the cause for hypocapnia. Hyperventilating, patient is hyperventilating, so check the ventilator settings, you can still come down ventilator settings. And improving gas exchange. When the patient starts improving, even the lung starts excreting the CO2, you can get hypocapnia. The treatment is going to be to decrease the sweep gas. Next is little more complex, is tissue hypoperfusion during ECMO, especially in VA ECMO. So when the patient is cardiogenic shock, you put the patient on ECMO. The intention of keeping the patient on ECMO in cardiogenic shock is to improve the not only the hemodynamics but also the tissue perfusion. That's the most important thing. So you have to see the parameters of tissue perfusion, whether they are improving or they are not improving, and your flow and your ECMO will be guided by tissue perfusion and not by your blood pressure or your SpO2. That's the most thing you should always keep in mind. Either you follow venous saturation or you follow the lactate levels. So how we diagnose tissue perfusion is inadequate oxygen to the tissue, diagnosed by low mixed venous saturation and elevated lactates. Clinically, you see the patient is cold, thin, clammy skin, cyanose, capillary filling time is still more, oliguria, with or without hypotension. See, hypotension is not the essential part of a poor tissue perfusion. So that's you have to always keep in mind. You might be patient severely vasoconstricted, pressures are fine, but still the tissue perfusion is not adequate. So, one of the guidelines is lactate levels. If the lactates are elevated, that can suggest you that tissue perfusion is not good. But remember, there can be other causes also of elevated lactate levels, like patient is anaerobic tissue metabolism. That is one of the reasons. But other causes are hepatic failure, catecholamine infusions, and renal failures. They can also increase lactate levels to some extent. So that also you have to keep in mind. If the patient is on adrenaline, you can have pseudo elevated lactate levels. If the patient is in hepatic failure, again the lactate levels can be high. So that may not be, lactate level may not be 100% reliable in that case. What will be more reliable in that case is going to be venous saturation. So in that case, you have to follow venous saturation. What is important? Lactate dynamics are very helpful. Then have one particular lactate levels. In a study, they said that if the lactate levels are decreasing in 24 to 40, 72 hours, it comes to baseline, normal, then the survival chance is better as compared to those whose lactate levels does not come down. So if your lactate levels, once you start ECMO, lactate levels start coming down, that will be a good sign. But if they still don't come down in next 24 to 72 hours, that means that is a predictor of poor outcome. The chances of survival is going to be less. So that is most important. You should always monitor that. So this is the blood lactate level in 48 hours. And those with blood lactate levels has come down to normal, the survival chances, the mortality was 40%, survival chance was 60%. But those whose lactate levels does not come down to normal, the chances are less. More the lactate levels, almost 100% to 90% mortality. So lactate level is one of the good predictor of your outcome that has to be kept in mind. Now, what are the causes of poor tissue perfusion? One is your inadequate cardiac output, inadequate oxygenation, hypoxia, both during VD or VA ECMO, your decrease in hemoglobin, or your increased consumption. See, when I talk about decrease in cardiac output, I mean both cardiac output from the heart, from the ECMO also. Okay. So inadequate cardiac output means either your ECMO flow is decreased, okay. So decreased, and that ECMO flow can be decreased because of either the preload is not inadequate, either there is something wrong with the circuit and that's the reason the flow is decreased. That is whatever we discuss about poor flow, or that the increased SVR due to vasoconstriction that can lead to decreased flow. Okay. Means whatever flow you are giving is not sufficient for that patient. You have to go up on that flow. Worsening cardiogenic shock. So when you started ECMO, you were doing well with 3 liters of flow. Patient improved. But then again you found that patient is going down. The reason is the cardiac contribution which was there has gone down. So what you need to do is, because the cardiac contribution has gone down, you cannot correct that. So you can go up on the flow and try to maintain the good cardiac output. That is what is most important. Okay. See, pulsatility is important. I don't say no. But the study says that if the pulsatility is not there, okay, if you maintain good flow, then there is not much difference between non-pulsatile flow and a pulsatile flow. The issue comes only when you have a null pulsatile flow and your cardiac output is low. If you can maintain pulsatile flow, well and good. But if you cannot maintain pulsatile flow and your tissue perfusion is still not adequate, then don't bother about the pulsatility. Pulsatility will come back. Keep on going high on the flow. You understood? So suppose at 3 liters of flow, you find that the pulsatility is going down. Okay. What you can do is, if patient is adequately supported, his hemodynamics are fine, his tissue perfusion is fine, you can try to come down to a flow of 2.7 liters and see if you can maintain pulsatility. That's okay. But at the 3 liters of flow, pulsatility is gone. At the same time, tissue perfusion is still poor. Don't bother about pulsatility. Go up on the flow and try to maintain the tissue perfusion. That is what is most important. So, contribution to the heart has decreased, which can be because of the deterioration in the cardiac function. That can be because of acidosis, electrolyte imbalance, some metabolic factors. The underlying condition can be worsened, reperfusion injury, or cardiac stenosis. Any of these causes will lead to decreased contribution from the heart, and that will overall will show a decreased cardiac output. Yes? Mic Jana. This mic. See, I'll tell you. If you compare a non-pulsatile flow and pulsatile flow is always better than non-pulsatile flow. That is dictum number 1. But more than that is the cardiac output, the tissue perfusion. If with the pulsatility you are maintaining tissue perfusion, we are happy. So what I say is at 3 liters of flow, suppose your venous saturation is 75, your lactate levels are normal, your mean arterial pressure is 80, then you don't require to keep mean arterial pressure of 80. You can come down to a flow of 2.75 and maintain pulsatility and accept mean BP of 70, accept venous saturation of 68, 70. Fine, because then you are avoiding cardiac stun. But if at the flow of 3 liters your mean BP is 60 or 55, your venous saturation is still 50, then there is no point in thinking about pulsatility. First think about adequate support. Okay. So always remember, as I keep on telling everywhere, I keep on using two words, adequate and safe. In the first word I use is adequate and second is safety. Understood? So always try to adequately support. See, why I am emphasizing this on this is we have done the same mistakes. We try to support initially we try to support the patient, and the moment the contractility was going down, we used to get scared and we never gone up in the flow. So we thought of safety first and then the adequacy, and we never get the result. And then we change our strategy. We say we adequately support the patient, we consider safety the second thing, and then we have been successful. And this is what you are going to get in each and every step when you do an ECMO. And that's the reason your balance distance is most important. Whenever you do ECMO, there will be many dilemmas. Whether to go up on the flow, because I tell you, when I discuss hypoxia, I tell you 4 methods of improving the hypoxia. You can cool the patient, you can increase the flow, you can increase the hemoglobin. So what to do at what time, that is most important. And your correct decision is going to help you to be a successful. Second thing that can be, the patient can go into a severe surge reaction. Okay. And that can again cause inadequate tissue perfusions. So delayed, that is because of delayed intervention. So you have to always remember, you have to start the ECMO in a reversible progressive shock. If you remember physiology, there is a stage where till there is a reversibility of shock. And after that, the patient goes into irreversible shock, and whatever you do, measures you do, there is not going to help. So that's the reason you have to always start off ECMO when patient is in the stage of reversibility. Can be secondary infection, which is leading to severe surge reaction. Because whenever you initiate ECMO, there is going to be mild to moderate surge reaction, which will become severe if it is associated with delayed intervention or infections. And what it will lead to? It will lead to vasodilatory state. You get vasoplasia, multi-organ failure, and capillary leak syndrome and fluid overload. So you will have a difficulty in getting the flow also. Somehow you manage the flow by giving more and more volume. You get patient becomes edematous, puffed up, and still you are not able to maintain the hemodynamics because patient is in severe vasodilatory state. So how you manage it? First is to assess the component of oxygen delivery. So whether there is a cardiac output is adequate or no, or oxygen content is adequate. So for VV ECMO, you have to give inotropic support to improve the cardiac output, and still in spite of that the cardiac output is low, then you have to think of converting it to VA ECMO or VAV. Okay? Because then it is not only a respiratory failure, but now it is respiratory failure with the cardiac failure which has also come into picture. That's a simple example of it. Patient of ARDS, you put the patient on ECMO, and then he is going to sepsis and develop septic myocarditis. And because of septic myocarditis, his cardiac output has gone down, and that is leading to poor perfusions. So you can easily think of starting some inotropic support, not responding, then you have to go and switch over to from VV to rather VA. I prefer VAV more. VA, if patient is on VA mode and patient goes into lookout RVMH, you have to increase the extracorporeal flow. Low oxygen content, output is okay, but oxygenation is low, hypoxia. One of the causes that I am going to discuss separately. In VV ECMO, it's going to be recirculation. If it is recirculation, you manage the recirculation, that I'll be discussing now. If the flow is less, we increase the extracorporeal flow, because in VV ECMO, whatever we say is that if the patient is hypoxia, you keep on increasing the blood flow. So to increase the blood flow. If that is also not helping, what you can do is transfuse the patient, try to get the hemoglobin up, and thereby try to maintain the oxygen delivery. So oxygen delivery is managed by three ways: by improving the oxygenation, by increasing the hemoglobin, or by increasing the cardiac output. And if that nothing else, then you think about cooling the patient so that your metabolic activity comes down and your oxygen requirement will be less. In a cardiac patient or VA ECMO, when the patient has got poor tissue perfusion, what can you do is to improve the tissue perfusion, you can increase the blood flow. You can use of inodilators, vasopressors or vasoconstrictors, and volume. So the pressures are low, all four things you can do it. You can do it, increase the flow and improve the pressure. You can increase, you can use the inodilators, you can use vasoconstrictors, or you can give volume and see how the response is. Important is what to do, and that is important. Which measure you will use in which case. So, if you have a low or normal mean arterial pressure, if the pulsatile is still preserved, pre-pump pressure is and hemoglobin is adequate, then what you need to do is you increase the ECMO flow. This means that the patient is not hypovolemic because the pre-pump pressure is not very negative. At the same time, your pulse pressure is maintained, so patient is not in a cardiac stunning. Okay. Your pressures are okay, but still the tissue perfusion is not good. Okay. That means patient still requires more flow, more cardiac output, and you have to increase the flow. But same patient, if you see that when the mean blood pressure is maintained, but the pulse pressure is less, say it's gone to less than 10. So your diagnosis is no pulsatility, your diagnosis is going to be your cardiac stunning. What you need to do is you can use some inodilators like dobutamine, bilirubin, adrenaline to have some cardiac contractility to increase cardiac output. Again, that is going to be in small dose, not to be in very high dose, so that you can maintain. So your inotropic score should not cross 10. You can maintain some cardiac contractility, and thereby you can improve the cardiac output and tissue perfusion. Third possibility is patient in a low cardiac output state, mean artery pressure is low with a good ECMO flow. Your flow is 5 liters, 6 liters, but still the mean artery pressure is low. Patient is probably in a vasodilatory state. Then what you need to give is vasoconstrictor, either in terms of vasopressin or noradrenaline, whichever you prefer. And if patient pre-pump pressure is low, means more negative, hemoglobin level is low, then in that case you can transfuse blood, or if hemoglobin is fine, you can transfuse fluids and get the pre-pump pressures more. So you increase the preload of the heart. That will help for the heart to even regain the cardiac contractility, because one of the cause for cardiac stunning is decreased preload. So you increase the preload, and that will help you to even improve the tissue perfusion in cardiac contractility. Is this clear? So that is what I put in this chart. Decrease cardiac output, native plus ECMO, hypoperfusion. What you have to do is increase the ECMO flow rate. Decrease hematocrit, transfuse PEG cells. Hypoxia, you have to find out the cause of hypoxia, that we will be discussing next, and treat it. Patient is restless, high grade fever, anything which will increase the metabolic activity is going to decrease. Your demand is increased, so you have to increase the supply. So you have to either you sedate the patient and reduce the temperature and maintain the temperature, and in case of VV ECMO, still the cardiac output is not able to maintain, you convert into VA ECMO. The next component is hypoxia. Many times you see patient is hypoxic still when the patient you are on ECMO. So factors which are affecting hypoxia and VV ECMO, this also I already discussed. ECMO flow, ECMO FIR2, ventilator settings, recirculation, lung status and oxygen status. These all things can affect the SpO2 when the patient on VV ECMO. SpO2 increase can because of decrease in the recirculation, lung condition is improving or increase ECMO flow or FIR2. SpO2 decrease, either recirculation is increased or lung condition is worsened. There can be some technical problems, oxidative failures, decreased ECMO flow and FIR2 or increased cardiac output. So whenever the patient is agitated, febrile, in anything which increases the metabolic activity, your cardiac output from the native cardiac output increases, your ECMO cardiac output is going to be the same. So there will be more dilution effect and that will lead to hypoxia in the VV ECMO. In VA ECMO, hypoxia is ECMO flow, ECMO FIR2 is less as compared to your native. So your native circulation increases. If patient on a VA ECMO, if you see PO2 low in an ABG, arterial PO2 is low, that means that patient native circulation is more than the ECMO circulation. That is the first possibility. And second possibility, your oxygen has failed. So your ECMO is not able to give proper oxygenated blood. So ECMO flow or ECMO FIR2, the cardiac status is improved, oxygenated status is worsened. Ventilator settings, somebody change the ventilator settings and the lung status is also improved. If the lung status is improved, again this is going to change. So increase on VA, lung condition is improved, increase ECMO flow or FIR2. Decrease, lung condition is worsened, increase cardiac output, the native cardiac output is increased. There can be some technical problems, oxygenator failure and decreased ECMO flow. So how will you manage this hypoxia? See, hypoxia we usually see more in VV ECMO as compared to VA ECMO. So what we do, we will maximize the blood flow through the ECMO so that we will increase the ECMO flow, blood flow, so the stability of hypoxia will improve. Increase the ECMO FIR2, usually we keep it 100, so there's no need of increasing further. Suppose we are in winning mode and then patient levels hypoxia, you have to increase the FIR2 to again to 100. If nothing is happening, then you can increase the hematocrit. At the same time, you try to minimize the oxygen utilization by decreasing the metabolic rate, by controlling the factors, fever, sedation, and induce hypothermia. And most important is decrease the recirculation. If it is there, decrease the recirculation. So maximize the blood flow through the system. You have to achieve highest possible blood flow. So you have to try to, if that is not helping, what you have to do is you can put 2 cannulas for a drainage and one return. So capture the greatest possible fraction of venous return, so you can get both. You are draining from the femur, the femur vena, inferior vena cava as well as from the superior vena cava. And the blood flow rate will depend upon the cannula size. If you are not adequately selected cannula size, you will not get proper blood flow. The cannula position is most important, okay, and the venous places. These are 3 things which is most important. Cannula configuration is that is a type of cannula, but anyway, we at present we are getting only one type of cannula, so there is no point in discussing cannula configuration. We don't have Avalon cannula, smart cannula, so there is no point. So always drainage cannula has to be bigger than return cannula. You have to match the cannula to the expected flow rate, and the chart I have already given to you. You have to keep that venous pressure less than 60-70, and your return pressures should be go more than 300. Otherwise, the chance of hemolysis will increase. So that has to be kept in mind. So cannula size we discussed, cannula configuration, dual drainage cannula or composite cannula. As I told you that we don't have any availability of that cannula right now. Cannula position, that is again most important. If the cannula position is proper, where should be your cannula position ideally? for a VV ECMO? Yeah, it has to be in hepatic IVC. Why? Why not above? Why not below? Yeah, if you go above hepatic IVC in RA, if it leads. See, hepatic IVC is non-collapsible. Your IVC is otherwise collapsible. Only hepatic IVC is non-collapsible. So if the cannula position is properly placed in the hepatic IVC, the IVC will not collapse, and that will decrease shuttering effects. So you will not get shuttering effects, and the endothelium of the vessel wall will not get damaged. Okay. In spite of low flow. So that is most important. So cannula position, I told you, it has to be the hepatic component of IVC. Next is maximizing the gas transfer. With the same flow, you try to maximize the gas transfer. As I told you, one of the ways, increasing hematocrit. So increase the hematocrit, the oxygen delivery will be more. See, with the same blood flow, there is a difference in oxygen delivery. If the blood flow is less, if the hematocrit is less, the oxygen delivery is going to be less. If the hematocrit is better, the oxygen delivery is better. Okay. So that is the reason. If you are if you are already on maximum flow, then in spite of going more on flow and increasing the chance of hemolysis, you can increase the hematocrits, and thereby you can maintain the oxygen delivery. That does not mean that at 3 liters of flow in adult, you transfuse the blood. No, I don't say that. I am very clear what I am saying is, if you are on already a flow of 5 liters, 6 liters, your pre-pump pressures are getting more negative, then rather than going further up on the flow to maintain the saturation, it's better to give to increase hematocrit. Because giving blood is also not absolutely safe. There are a lot of adverse effects associated with that also. So you have to balance yourself. If you are on flow of 3 liters, please go up on the flow. But if you are already on a high flow, your pre-pump pressures are very negative. In that case, better to give a transfusion that will help to get your pre-pump pressures down also. And at the same time, it will improve the oxygen delivery. So hematocrit, as the hematocrit increases, the PO2 level also increases. So another thing is by decreasing the utilization of oxygenation. So what you do? You can cool the patient. If you cool the patient, see the PO2 level goes up. The oxygen consumption increases as the temperature increases. If the temperature is low, 34, the consumption is low. So when the consumption is low, definitely the PO2 level will increase. So if nothing helps, then you can think of cooling the patients. But the cooling the patient is not the first option. Okay, cooling the patient is not the first option. That is a last resource, or I'll say second last resource. And this does not help, then the last resource is from VV, you switch over to VAV. Okay. So what are the problems with come across VV ECMO? Cable collapse, that is suction effect, that is I already discussed. Effect of native cardiac output. So as soon as the cardiac output increases, your ECMO flow is same, you get hypoxia because the dilution effect will be more. So in that case, you have to decrease the cardiac output in terms of by sedation, by controlling the temperature. If patient is on inotropic support, come down on inotropic support, etc. And the most important, that is recirculation. I discussed. See this color. So this is color. This is a two drainage canal. Switch drainage, IVC drainage, and this is the return. You can see these two colors are almost same. So there is a lot of recirculation occurring. Okay? And the reason for that is this is the return cannula, this is the drainage cannula. Return cannula is almost come down to the lower RA or coming down below the RA levels. So in that case, you get more likely to get recirculation. The correct position should have been somewhere in the mid RA. So because your jugular cannula has gone down, okay, that is causing recirculation. What you need to do is you just take up the cannula. Now, see, SVG drainage, usually what I see, you can take it, either you can take it from the opposite IJV, or ideal is to put a cephalad cannula. Nobody does it in practice. Cephalad cannula is you put the, you puncture the same jugular vein and go up. That should be an ideal because that will give you the maximum deoxygenated blood from the superior vena, from the brain. That will give you accurate your brain venous saturation. So that will also help you, and you get a good absolutely non-recirculated blood, and that will help you to maximum. So the first choice, if you have to put an additional cannula, is to put cephalad cannula, but it's difficult to put it and difficult to maintain it. So nobody usually does it. Alternative is to be in RA, in the mid RA. What you do is you go up to mid RA for arterial return. You keep the IJV cannula, don't let the IJV cannula to go into RA. Okay. That will not go into RA, that will remain in the. No, put in the opposite side. Usually what we do is, if we require to put two cannulas, one in IVC and one in SVC, what we do is the return cannula, which is there, okay. Usually what I do is then I convert that right femoral jugular cannula, which is 29 French, as a return cannula. I push it further up and put it in mid RA. I put another cannula of 21 French in the femoral vessel, opposite femoral, and I keep this jugular cannula as a drainage. Now I switch out this cannula to drainage. So I am draining from right jugular, which is 21 French. I am draining from left femoral, which is 21 French, and giving return to the right femoral, which is going to RA now. Instead of hepatic IVC, it goes in the RA, and it is giving a return. Okay. So you are getting desaturated blood from here, deoxygenated blood from here, and you are supplying oxygenated blood to the RA directly. So usually, this is how the flow is. But in case of recirculation, the same blood returns back to the drainage, and you get a recirculation. Because of recirculation, the effective blood which is going to the RA will not be there. So you get hypoxia. And as I told, the last resource is convert from VV ECMO to VA ECMO. And what are the causes for switch out to VA ECMO is? You might require circulatory support, right heart dilatations, and failure to support the gas exchange adequately. Then you think of switching from VV to VA. So what are the causes? Can be disconnection of the pipeline, as I said, first think of technical issues. Look for the proper connection. Can be patient restless, metabolic activity increases, hypoxia. More cardiac output because of any reason, again hypoxia. Oxygenator failure, membrane edema or oxygenator failure because clogging, that can lead to hypoxia. Demand more than slow, anything which leads to increased metabolic activity will lead to this. Low effort from the ECMO. So these are all technical aspects. High recirculation in case of VV ECMO, and patient is receiving less flow due to loose clamp of bridge. That is again only possible when even your flow is okay, you have started, but if you have kept the bridge inside and your bridge, somebody opens the bridge, then what will happen? The blood is going, some amount of blood is passing through the bridge. So that is not coming into the circulation. So this is how you will start thinking when there's hypoxia. Check all the parameters, your ECMO FID, your ventilator FID, ventilator PEEP, everything, whatever you said is the same or just changed. If everything is fine, then check the delta pressures. Because the delta pressure has gone up, that means oxygen has failed. If the delta pressure remains the same, then you have to think about something else. So it's very easy if the delta pressure has gone up, do post-oxygenated blood gas. If post-oxygenated blood gas is also showing hypoxia, it means that it is a very simple, it's just oxygenator which is failed, you have to change the oxygen, things will be fine. If your post-oxygenated blood gas is normal and your delta, the delta pressure is normal, either in these two cases, what can be another thing is you have to think about recirculation. You have to think about recirculation. So how do you calculate recirculation? You see the color of the tubes. And second thing is you can measure recirculation by a formula pre-oxy saturation minus venous saturation and post-oxy saturation minus venous saturation. The fraction of this becomes the recirculation. So you can calculate recirculation by collecting the blood from the pre-oxygenated line, post-oxygenated line, see the PO2, SpO2 of both, saturation of both, pre-oxy and post-oxy, and you have to take a blood from the some central vein, which is away from your returning cannula. So if you have femoral line, you can take the blood from the femoral line, that will give you a venous saturation. Because you cannot take it from the jugular line, because if it is close to your return cannula. So, and if you minus that, whatever the fraction you get is a recirculation. If the recirculation is up to 30%, that is acceptable. See, if you have a jugular line which is, so you usually put a jugular line on the left side. So if you have a left side jugular line and which is away from the returning cannula, it's not enter the RA, then you can take it from that. That is reliable. If that is not there, the only way you can collect is from the femoral. That will be somewhat reliable as compared to others. So the recirculation is more than 30%. What you need to do is you decrease the blood flow. That will improve the. If that does not also improve, then your cannula position, you check the cannula position. Okay. And if once you change the cannula position, it might improve recirculation. If that does not improve the recirculation, then you have to put one more cannula. And as I told you, you have to switch off to VVV ECMO, draining from IVC, SVC, draining from IVC, and returning to the RA. If your recirculation is not there, is less than 30, then check the pre-pump pressures. That it means what? The recirculation is not a problem. There are no technical issue. That means that you need to give more flow, more support. So you have to increase the flow. If you increase the flow, patient becomes more negative, then you have to give fluid and then increase the flow. And if still you are not able to maintain good flow, then put one more cannula and switch over to VVV. And then the oxygen is falling, you will change the oxygenator. Decreasing the flow will correct hypoxia. Yeah, I'll tell you. In fact, I'll discuss recirculation separately, and that time I'll tell you. But what happens is, as you increase the flow, the recirculation flow increases, but your effective flow decreases. So that's the reason you have to decrease the flow, then you get more effective flow than recirculation. But that I'll discuss as a separate topic. And similarly, hypoxia in a VA ECMO, you have to check the delta pressure. If delta pressure is fine, then your native cardiac output is increasing, then you increase the ECMO flow. And if you have to increase the ECMO flow, again you have to check whether the pre-pump pressure is negative or positive. If it is more negative, then you have to give fluid and then increase the flow. So in short, what you need to remember, you control CO2 with the help of sweep gas. Control PO2 with the help of blood flow. Do not exceed pressure limits. I'll just keep that in mind. Maintain good venous pressure for good drainage. Dual cannulate if hypoxia persists. So don't worry about adding one more cannula. Be aware of recirculation. If nothing else, cool the patient. Maintain hematocrits. What is most important is give rest to the lungs. That is most important. You do everything, but don't increase the ventilator settings. You increase the flow, you give hematocrits, you cool the patient, you switch off from VB to VA, but don't increase ventilator setting because you want to give rest to the lungs. And as a last resort, switch from VB to VA.